Hi, I'm Patrick Basu from Clinical Professor of Columbia University and Weill Cornell Medical Center, New York. Today is going to be a tantalizing subject. This subject is really kept in the closet for a long time. It's celiac disease. So, give me a little bit of background, historical background. Actually, it came back a few hundred years ago in Greece, and then particularly now in Turkey, called Cappadocia. The people involved in that part, when they suggested that it might be some forms of carbohydrate intolerance, but the first individual came up named Samuel Guy. So Dr. Guy was the first protagonist. They found out there's something else with diarrhea. It's not really from carbohydrate and milk, but there would be an overlap. Then what happens in Dutch famine in 1944, people are dying, particularly kids are dying, they thought it's the carbohydrate-induced malabsorption. But when the famine occurred, there was no bread or pasta or anything else, only potatoes. So in this case, they found out the mortality dropped 35%. And that time, they realized that his name is Dickey. So that Dr. Dickey found out, I said, no, there must be some correlation between this particular bread and bread products, particularly rye, wheat, and spelt. So these have something to do with this. And then later on, Dr. Pauling in England looked into a lot of tissues. They had surgery done because they thought it's some forms of inflammatory bowel, people losing weight and malabsorption and maldigestions. And then they said, no, it's not the histology. The tissue is not the tissue of Crohn's disease or inflammatory bowel disease. They looked into it. They have a different patterns of the villi, small bowel. So that ignited a huge scientific research. But that done, in 1965 was the first time they looked into that part from the pathological aspect. By the way, the prevalence of the disease actually not known. They thought, well, this disease is only in Europe. Why in Europe? Because European babies, when they're 6 months old, Eastern Europe, Western Europe, Southern Europe, they give pasta or tiny pasta, which is vermicelli or whatever. That's purely, and then bread. And that bread and pasta contains something, a protein called gluten. We're going to talk about the gluten just a little bit later. So now what happens with this, but the whole prevalence they found, global prevalence come about, in America it's from the Mayo Clinic. So Mayo Clinic's mostly all Caucasians actually, but they found out even in South America, Latin America, Central America, India, Bangladesh, China. So the paradox is in China and Japan, what they have the staple is rice. But in that case, in rice eaters, they develop this. So in that case, this is a confounding, a very confusing state. Then it's found out that this is a protein. By definition, the prevalence in that world is 1% or 1.5%. It depends on demographic, geographical distribution. In South America, it could be 2.5%. Even in Africa, particularly Northern Africa, where the Berber tribe and Tunisia or Algeria were significant predominance. So now this disease actually is it's called by definition, which is consensus actually, called immune-induced enteropathy. What do you mean by enteropathy? The small bowel is enteropathy. So give you a very nice analogy with a little bit of animations. So small bowel has villi. Villi means the cell structures like my finger. Why nature gives that? Because if you open and unfold all this structure, it's bigger than a soccer field. Why is that? Because amount of absorptions and water go back and forth every day. It's about 7 liters. And the amount of absorptions, vitamin, elements, materials, so much from there. So in this case, that's why the nature. But again, if you look at carefully, so what happens? This is the villi, and there is a dip, and dip is called crypts of Lyracle. So what happens normally, physiologically, is 3:1. One is changes, that means when this crypt altered behaviors equal to ratio 1:1, that means the flattened villi. So what happens in pathology, biology is when this gluten and choline and serine, there are other two, but gluten is the predominant thing, which is actually from bread, rye, and spelt, and these and some forms of non-contaminated oats. It's not contaminated oats. Contaminated oat means in the island the oat is not contaminated. In this here wheat field, after that they put the oat, there is a cross-contamination, and that can cause again gluten. So this gluten actually comes in. So our bodies, when we are children, particularly 6 months old, what happens? Our immune system is not that developed. We get here mother's milk and mother's immunoglobulin. But here, the dewdrops of this is called immunoglobulin A as apple. So what happens? So this time, this immunoglobulin A is not that active or apt. So these, gluten that time, perceives that time in the small bowel as a foreign particle called antigen or new antigen. So any foreign particle at that time, it makes the body's immune system a little confused or wake them up. So while they are waking up, that means as perceived as a foreign particle, foreign protein, so they have our immune cells, and we are called destined type of immune cell called CD3, CD4, and CD8. These cells actually come and bombard to fight. So there are two forms of immunity here. One is called innate immunity and one is adaptive immunity. In this case, there are other vehicles. So innate immunity, we have all these chemokines, interferon gamma, but adaptive immunity is a bunch of called cytokines. Cytokines are interleukin 1, 2, 3, 4, 6, 8, and TNF alpha. TNF alpha is a tissue necrosis alpha. So TNF alpha eventually come up and bombard these tissues as a fight. It's called NF kappa B. So that's the hologram and the hallmark of immune destruction. But all these people, they, unless they have perceived gluten, that gluten has to be toxic gluten. What does it mean by this? We have enzymes, that enzymes switches gluten to a form of an amino acid called glutamate to glutamine. So why glutamine? This glutamine is the real fair food for this enterocytes or colonocytes, the cells. So there is disruption of glutamine. There is an enzyme called tissue transglutaminase. Remember, glutaminase means changes glutamate to glutamine. The tissue transglutaminase, of course, is immunoglobulin IgA, are either defective or biologically inactive or non-functioning, or they have antibodies. So that is the problem when that gluten becomes toxic. And that toxic gluten induces more injury, brings more cells, immune cells, to fight. So look at this structure again. This structure, we have, for instance, make it a 10-family house. So in 10-family house, there are 10 families. So when there's immune bombardments, there are millions of people coming in as a refugee or rescue. What happens? They need more space. In this case, what happens? They follow. They fold. To fold, why? To give this more space. So while they are folding, look at the ratio is changing. That means 3:1 is changing. It's practically maybe 2:1 or 1:1. And then more immune cells coming, they are flattened. Once they are flattened, that means the entire index of ratio has changed completely. And that called villus atrophy, and that causes a big problem of absorptions, malnutritions, maldigestions, diarrhea, and many things. So this is the hallmark of immune biology of celiac disease. So what happens? What are the manifestations? People thought that kids or somehow the phenotypes. So celiac disease, not all people have gluten challenge will have celiac. You have to have a destined, designated genotype. That means you have to have an affected gene, and these are called DQ2 and DQ8. So these are a lot of genetic predilections, but all DQ8 is not possible. There are some variability, and DQ2, of course, specificity. They call it heterodimer and isotopes. These are two fancy words, but remember, unless you are genetically disposed. So remember, one gene means we can have the gene. That doesn't mean we'll have the disease. They call genotype and a phenotype. So the phenotypical part of the disease, which gives you symptoms, clinical signs, and morbidity and mortality, the celiac disease starts actually not early age. So you can have the natural history with this disease process smoldering from the age of 14, 9, 10, but actually the overt presentations of phenotype can be 30s. So what are the presentations? The presentations of the bowel means the small bowel, malabsorption, deficiency of vitamin, particularly vitamin A, D, E, and K, vitamin B12, and iron. So that means this disease can cause iron deficiency anemia. If you give them iron, they don't absorb the iron. So it's a resistant type of iron deficiency anemia. Number one. Others, nutritional depletions. Others, they have non-luminal, means extra luminal, means it's a The number one called immune syndromes. Number one, immune system thyroiditis. They can develop alopecia. They can develop seizure. They can develop mental retardation, short stature, osteopenia, rickets, osteoporosis, hair loss, and they can have ataxia, peripheral neuropathy, and pancreatitis, even myocarditis, and thyroiditis, and most important is insulin-requiring diabetes mellitus. Remember, insulin-requiring diabetes. The people have a higher predilections. Who are they? Down syndrome, Turner syndrome, and other these syndromes, but they usually have other parameters as well. The most off the bat, I give you the example. So these are the extracolonic, extra luminal manifestations, and most important manifestation is fatigue, and fatigue. So people with chronic fatigue syndrome, they must look into. There is an overlap called bacterial overgrowth, which can cause any denuded, means any loss of the life. The bacteria retrograde walks up from the colon, and what happens? Giving bloating. And a lot of people think that bloating is from or a disaccharide deficiency, means lactose, lactase, maltose, isomaltase, sucrase, all these deficiencies. With celiac disease can have an overlap of lactose intolerance and bloating and pain and diarrhea. On top, they have an overlap with irritable bowel syndrome. So anybody with irritable bowel syndrome must rule out celiac disease. Anybody with inflammatory bowel disease like Crohn's disease must rule out celiac disease. There are some liver disease as well that has association with celiac disease called primary biliary cholangiopathy and primary sclerosing cholangiopathy, or autoimmune pancreatitis. So there are so many other immune disorders can have celiac disease. So manifestations we talked about, it can cause even constipation, sometimes 5%, cause diarrhea, would be 5 to 35%. It depends, diarrhea occurs if you acquire the disease much earlier. So now what you do, the only therapy is non-taking any gluten, completely restriction of gluten for life. So what happens in this case? There are three, it's like an iceberg. There are three components of celiac disease. One is called silent celiac disease, one is called latent celiac disease, and one is called blatant celiac disease. Blatant celiac disease, all these tissue transglutaminase and other antibodies would be positive, called endomysial antibodies, and you have to quantitate the immunoglobulin A level. Because Giardia and others, if you drop so much diarrhea, if you do, you lose immunoglobulin A. All the antibodies are with immunoglobulin A. I didn't tell you about another skin disease, which is very common. Actually, 2% cases with celiac disease can have it. It's called herpetiformis, dermatitis herpetiformis. There are some type of herpetiform lesions on your elbows, on your knee, on your back. Painful. But again, 40% cases, 60% cases actually, in these dermatitis herpetiformis, there's no celiac status by biochemical evidence. So it's a confusing stuff. You have to do that skin biopsy and look into immunohistostains, immunohistochemical stains of immunoglobulin A. It can cause kidney disease as well, celiac disease, and glomerulonephritis or Burgess disease. There's a huge amount of protein losing part. There are so many systemic diseases associated with celiac disease. Celiac disease eventually can cause adenoma and a bad cancer of lymphoma called ETL, which is enteropathy associated, EATL, enteropathy associated T-cell lymphoma. This is treatment is bad. May develop eventually such a resistant type of celiac disease where you need immunosuppressive drug like cyclosporin, azathioprine, and also initially steroid. Eventually, we are having a trial with mycophenolate mofetil, Celiac, and last resort is even bone marrow transplantation. So this disease, and very rarely it can cause squamous cell carcinoma of the esophagus. So there is a lot of potentials of carcinoma. So how you diagnose this disease? Again, simply blood test. You have to tell your doctor to do a tissue transglutaminase 2 antibody, endomysial antibody, and another one called DGP, which is the most specific antibody, is called diamino peptide. So DGP, deaminated gliadin peptide, which is a corroborating confirmatory test. But again, you can do a biopsy. Biopsy in latent celiac disease, the mucosa is normal. In silent celiac disease, it might be mild. So there is a pathologist called Marsh. So William Marsh actually looked into and classified the biopsy. Marsh 0, Marsh 1, 2, 3, and 4. So Marsh 0 is normal. Marsh 1 is semi-normal. Marsh 2 is some blunted villi. Marsh 3 is blunted, and Marsh 4 is completely blunted villi. And then you can measure the CD3, CD4 count. It has to be minimal over 20 to 40. That's very esoteric test. We don't do it. But clinically, if you have all these symptomatologies, okay, so what you do, take a simple blood test, tissue transglutaminase 2, endomysial antibody IgA, and DGP, which is called deaminated glycine peptide, and altogether immunoglobulin A measurement. That's it. That gives you the really 99% even sensitivity and specificity about 85%. And then what you do an endoscopy and biopsy. Please make at least 4 biopsies to 6 biopsies because you can miss one. And then they can have an immunohistostain as well. And you can see the biopsy would be flattened mucosa. There's some fold changes like clamshell. There's seat, like a sawtooth appearance. There will be mosaic pattern, all this stuff. But if you biopsy and look into it, and that will be celiac disease. So how do you treat celiac disease? Again and again and again. No gluten, but you have to be very careful because all the restaurants you go to, there are 33,000 gluten-free diet all over. Any website you go to, they'll send you. And what you can eat amongst all these grains, you can eat millet seed, and sorghum. Otherwise, you can eat rice, you can eat tapioca, you can eat potatoes, you can eat so much. Now alcohol, yes, the grain alcohol you should not, but if you want to drink vodka, there is actually potato vodka. Now in Finland, to Poland, to everywhere, they can potato vodka. In beer, there are celiac beer, particularly one beer in Australia. I cannot give you the name because I'm not working for any industries, so disclaimer is. And that's why there are celiac beer and everything. There's one new entity which could be an overlap, is called gluten sensitivity. These people are non-really celiac. The status of the celiac biochemically and biopsy is negative, but they feel good if you stop the gluten, which usually occurs to a lot of women. That's a fad now. Everybody's gluten sensitive. But again, it's good because if you stop the gluten, then they find out that their well-being and quality of life and bloating thing is much better, and they have less fatigue. They feel good. So the diagnosis is, I showed, simple test. You have to have an index of suspicion, and you have to see exactly anybody suffers. And then what you do is, if it's iron deficiency anemia, not being treated with iron or not reactive to iron, type 1 diabetes, then peripheral neuropathy, unexplained seizure, growth pattern is inter, and mental retardations, and thyroiditis to so many autoimmune syndrome. And if they have Down syndrome or Turner syndrome or any forms of immune disorder, you must do this simple blood test. If the blood test is positive or quasi-positive, you have to do the gene testing called HLA, DQ2 and DQ8, then you can do biopsy. So how you monitor this after not giving gluten and being very retentive to gluten, and there is a chance of cross-contamination. Remember, one bread contains 10 grams of gluten. If you use husband-wife, the same toaster, you'll be contaminated. Same frying pan is contaminated. So you have to be strict. Everywhere you have to call in the restaurants of any family house, particularly Passover, the matzah and others. If you go to church again, you have to tell celiac because now they even Pope change into it, the Christian Catholic law. They give you rice, that's the Eucharist, Christ's body. Or if in matzah, if you're Jewish, Passover, they can have a matzah made of spelt or something else. And other religion-wise, if you have, they can change this to now. So now there is so much awareness, and people are looking. Last 30 years, we have barrage of evidence, and we want to research. And we've got to know the disease much more. But again, how do you screen? First degree relative with a blatant celiac, you should screen. Okay, first degree relative. So people with other concomitant disease process, we have to screen, and then follow up with again. So every time you don't have to do endoscopies, but once somebody is retentive, you can go back and look at it and see the villi structure, from Mars 4-3, it can regress to a normal, near normalcy. But if it is a resistant pattern of celiac, despite being completely retentive, then we have to start steroid and then go to a special doctor. This is also a celiac center approved, and if you go to an AGA celiac site, I give the talk on their YouTube, and otherwise please look up www.gastrospecialist.com. Again, www.gastrospecialist.com. And thank you for listening.